reaction is going to be FNHTR. What is that? Febrile non-hemolytic transfusion reaction. It is a febrile non-hemolytic transfusion reaction. इसका मतलब बुखार, fever. Yes. So please remember, most common transfusion reaction after the BT beta, it is febrile non-hemolytic transfusion reaction or fever. Mild fever है तो treatment will be antipyretics like paracetamol. But if it is a severe fever, then stop the transfusion. Clear? Next important, if I talk about the second transfusion reaction, which is deadly beta, that is known as ABO incompatibility, also known as mismatched blood transfusion. So ABO incompatibility is nothing else but a mismatched blood transfusion. That is, in an A positive patient, you are giving a B positive blood. That is important. It is which type of hypersensitivity? Very good. So we know beta that your ABO incompatibility is going to be a type 2 hypersensitivity, that is either called a cytotoxic or an antibody mediated hypersensitivity. The preformed antibodies are actually going to target the new RBCs beta. What is the most common cause of ABO incompatibility? Yes, the most common cause of ABO incompatibility is nothing else but clerical error beta. Now, when we say clerical error, that means what? Clerical error means error in some clerk-like work beta. That is sticking the label or updating the information. उसमें कुछ गड़बड़ हो गई है. That is called as clerical error basically. Next, what is the most common symptom? Symptom means what the patient is going to tell you. Very good. The patient is going to have a pain and a burning or a pain and a heat sensation along the vein. From whichever vein, definitely beta, you're giving the blood transfusion. Along that vein, patient will experience a lot of pain and heat sensation beta. What is the most common sign now? Very good. The most common sign that you will identify beta is nothing else but decreased urine output, and decreased urine output is known as oliguria. Why? Because we know in ABO incompatibility, the large clumps are formed in the circulation. They go and block the glomerulus beta, decreasing the urine output of the patient, causing oliguria. If oliguria is not an option, second most common sign is going to be. So please remember, beta, the second most common sign is going to be hemoglobinuria. Why? Because we know the antibodies are going to target the RBCs and cause hemolysis, due to which the patient will have a hemoglobin urea beta. That is a dark color urine. Okay? So that is important. If they ask you what is the most common sign in an anesthetized patient, so we know the most common sign is going to be generalized oozing out of blood. Okay? From the surgical site. Yes. So please remember, generalized oozing out of blood definitely is going to happen बच्चे in cases of ABO incompatibility. ठीक है? When the patient is under the influence of anesthesia, generalized oozing out of blood without any injury, still there is oozing out of blood which happens. Treatment, if they ask you, beta, what should be the treatment in patients of ABO incompatibility? Very good. We know the first and the foremost step is nothing else but stop the BT immediately, beta. So stop the blood transfusion immediately. That has to be the treatment. Along with that, we have to give 3 drugs to the patient beta. What are the 3 drugs? First is injection of steroids. We know we have to stop that immune reaction beta. So we have to give steroids, that is injection of hydrocortisone. Next important, we have to give an antihistaminic drug known as Avil. Okay, so Avil, which is there beta, it is nothing else but phenyramine, which is given over here. And third, to increase the urine output, we will give diuretics. Which diuretics are given in emergency? The faster acting, that is loop diuretics known as furosemide or Lasix beta, that has to be given in the patient. Clear? To stop the BT and give these 3 drugs beta to the patient. That is what is done in patients of ABO incompatibility. Now, what is the definition of massive blood transfusion if they ask you beta? हमें पता है massive blood transfusion की अगर हम बात करें तो it is nothing else but replacement of the whole blood volume beta, okay, or giving 10 units of blood within a span of how many hours? Within 24 hours. So replacing the whole blood volume within 24 hours or transfusion of 10 units of blood within 24 hours. Both is considered as massive blood transfusion. Or giving how many units of blood within 1 hour? Very good. Another definition will be if you have given 4 units of blood within 1 hour beta, that is also considered as a massive blood transfusion. Do remember the definitions: 10 units within 24 hours or 4 units within a span of 1 hour. Both of that is a massive BT. Now, if they ask you in massive blood transfusion, we know there is a lethal triad beta. Okay, those three things which can cause death of the patient. What are those three things? First, we know during the massive blood transfusion beta, it is not possible to do proper warming of each and every blood bag. Why? Because we know the blood bag, PRBC or whole blood, it is stored at what temperature? Very good. The storage of blood temperature, the storage of temperature the temperature of storage basically beta, it is around plus 4 degrees Celsius. The range can be 2 to 6 degrees Celsius. Therefore, warming of blood is necessary before transfusion. If warming is not adequately done, that causes hypothermia in the patient. Second, we know the blood is stored at a pH of 6.2. So therefore, the patient will develop metabolic acidosis. And due to hypothermia and acidosis beta, the homeostasis of the body gets disturbed and that leads to coagulopathy beta. The patient continues to bleed more and more because clots do not form. That is what is important to be remembered beta. These are the three major things in the lethal triad of massive blood transfusion. Now, to avoid this coagulopathy beta after a massive blood transfusion, we don't only give packed RBCs to the patient. Along with packed RBCs, we give fresh frozen plasma and platelet-rich plasma. So never only give a packed RBC or whole blood in the massive BT. Along with that, always give fresh frozen plasma and platelet-rich plasma beta to avoid coagulopathy. That should be given in a ratio of 6 is to 6 is to 6. The ratio that you have to maintain is 1 is to 1 is to 1. But during massive BT, we give a amount of 6 is to 6 is to 6 beta. That is important. Now, after a massive BT, what is going to be the most common complication? Very good. We know if a massive blood transfusion is given in an elderly patient or an anemic patient where the heart is weaker, obviously that patient is going to develop CHF. That is nothing else but congestive heart failure beta. That is what is important to be remembered. Now, important is if I ask you that all the ions are going to increase or decrease after a massive blood transfusion. Decrease beta, right? There will be hypocalcemia, there will be hypomagnesemia, there will be hypophosphatemia, except very good. So we know that the only ion that increases after a massive blood transfusion is potassium beta, and the patient is going to develop hyperkalemia due to two reasons. One is due to hemolysis, and second is due to acidosis beta. Okay, these are known to cause hyperkalemia, and hyperkalemia can increase the risk of arrhythmias in the patient. Clear? So yaad rakhna, all the ions decrease after massive BT except potassium, which increases. That is hyperkalemia, which is seen. Next, if they ask you what is going to be the most common cause of death after a massive blood transfusion, the most common cause of death after a massive blood transfusion, answer has to be DIC beta. That is nothing else but disseminated intravascular coagulopathy. So DIC is the most common cause of death after a massive blood transfusion. That is what is important again to be remembered. Understood? Okay. So these are the major complications. Apart from that, if I talk about the two important complications, beta, okay, one is going to be TRALI, that is transfusion related acute lung injury, and second is going to be TACO, that is transfusion associated cardiac or circulatory overload beta. Now, please tell me, both the patients are going to develop a pulmonary edema. Dono ke dono patients mein there will be a pulmonary edema. But what is the difference? In TRALI, which kind of pulmonary edema will be there? TRALI mein which kind of pulmonary edema? So please remember, TRALI mein the patient is going to have a non-cardiogenic pulmonary edema beta, where the patient does not have any heart failure beta. The pulmonary edema develops due to pulmonary vasculitis. But in TACO, the pulmonary edema is going to be cardiogenic in nature beta. Why? Because we know that in cases of TACO, the patient initially develops CHF or congestive heart failure. And due to that, subsequently, the patient develops pulmonary edema. So it is a cardiogenic pulmonary edema. इसी वजह से you know the major differences beta now. We know if I look at the chest x-ray of both these patients beta, what I'll find that the CT ratio which is there, bache, the CT ratio, it is normal in which condition? TRALI. And more in which condition? TACO. So we know that the CT ratio is normal in cases of TRALI but increased in cases of TACO beta. Second important, we have to make a difference with the help of BNP. What is BNP? Brain natriuretic peptide. So brain natriuretic peptide is released during congestive heart failure. And we know CHF occurs during TACO. So BNP levels are high in TACO, whereas normal in Trali. That is how you differentiate beta. Clear? Important. If I talk about Trali, here the problem is only a pulmonary edema. So patient only complains of respiratory distress. Treatment is low volume ventilation beta. Oxygen should be given at a low pressure. Next, taco may we know beta, the patient is actually having a congestive heart failure. So apart from respiratory distress, other signs of heart failure will be present. Like the patient will have facial and pedal edema. Patient will have increased JVP. Patient may have hepatomegaly or even ascites for that matter. And in this patient, what should be the treatment? We know as it occurs due to CHF or volume overload, we have to give loop diuretics like furosemide beta again. Clear? So that is what is important to remember. Chalo. Next important, if I talk about are these instruments. The first instrument is, yes, the first instrument is a Rice tube beta, also called as a nasogastric tube. So please remember the first instrument is the nasogastric tube or the Rice tube basically. Now, nasogastric or the Rice tube is inserted in sitting or supine position. It is inserted in a sitting position beta with neck in flexion or neck in extension. The neck should be in slight flexion. That is what is important. How do you confirm the correct placement or the correct positioning of the nasogastric tube? Two methods. First, I will connect an empty syringe beta and I will definitely try to aspirate the gastric contents. If I am able to aspirate gastric contents in the syringe, that means the tube is correctly placed in the stomach. Second, I will push air with the help of an empty syringe and I will auscultate over the epigastrium. So if I'm able to hear a gush of air beta, okay, over the epigastrium during auscultation, I say that the tube is rightly placed inside the stomach. Clear? So, though method. Chest X-ray is not used beta to confirm the correct placement of the nasogastric tube. Only one condition, esophageal atresia with fistula beta. Only that condition may, after insertion of the NG tube beta, we perform a chest X-ray. Otherwise, we never do a chest X-ray beta. That is important. Next important, if I talk about, please tell me, रुक तो जाओ. Now, important is what is the most common complication of the nasogastria? What is the most common complication associated with the nasogastric tube or the nasogastric feeding beta? Most common problem क्या होता है? Most common or most common migration or displacement of tube beta. Clear? So please remember, either you can say migration or you can say displacement of the tube. Tube अपनी जगह से हिल जाती है, ठीक है? So please remember, migration of tube or displacement of tube is going to be the most common complication definitely associated with any tube feeding beta. That is important. Other complications, yes, can be blockage of the tube as well beta, can be infections as well beta. Important, if they ask you that what is going to be the feeding related complication, तो answer क्या होगा? Feeding related complication. Now we know whenever we do tube feeding in a patient beta, we should definitely not give hyperosmolar food. Okay? If you give hyperosmolar food, the patient is going to develop osmotic diarrhea. याद रखना, the feeding related complication can be osmotic diarrhea in the patient or even bloating for that matter. ठीक है? तो osmotic diarrhea or bloating like features can happen, okay, as feeding related complications. Hopefully remember. Next important, if they ask you beta, it is going to be this instrument over here. What is this? This is nothing else but your urinary catheter known as Foley's catheter beta. If I talk about the Foley's catheter definitely, so please remember, normally it has only two ports beta. One port is basically for the urine to come out. Second port is for inflate the balloon beta. Inflation of balloon is preferably done with which fluid? Distilled water beta. ठीक है, preferably distilled water should be used for inflation of this balloon beta. Reason is this normal saline या sodium chloride जो होता है, it is going to crystallize after some time and it will make the balloon or the cuff harder, due to which beta removal will be difficult. ठीक है, that is what is important. तो इसीलिए distilled water is the preferred fluid for inflating the balloon in the Foley's catheter. Clear? Now, important is definitely beta. We know the sizes of cannulas and needles are measured in gauge. Okay, so please remember that sizes of needles and cannulas are measured in gauge beta, but the sizes of catheters and tubes are measured in French. So we know the green one which is there beta. It is a 14 French catheter, generally used for females beta. Whereas if I talk about orange one, the orange one is a 16 French catheter beta and generally used for adult males. We know the black and the white catheters are usually 8 or 10 French catheters beta, and they are generally used for children or pediatric patients. Clear? And this is which Foley's beta? How many ports are there? Three ports. So the third port is basically for bladder wash beta, right? So whenever you have to perform a bladder wash or a bladder irrigation, like in patients of hematuria, so in those patients, which I need a three-way Foley's. So three-way Foley's is necessary for the purpose of bladder wash or bladder irrigation beta. That is important to be remembered. Next, what is the next catheter? Very good. The next catheter is Fogarty's beta. You can see it is extremely long catheter. It also has a balloon associated, balloon attached to it beta. So this is the classical Fogarty's catheter, generally used for which kind of problems? Yes, it is generally used for vascular problems, beta, like whenever you have to remove a embolus or a thrombus. Secondly, whenever you have to break a plaque, basically, beta, right? So Fogarty's vascular catheter is generally used for which procedures? Fogarty's vascular catheter is generally used for procedures like angioplasty, like in patients of atherosclerosis, beta. Okay, the last option that we have, sorry, the second last option that we have is an angioplasty beta. Okay, where either we can break that atherosclerotic plaque with the help of inflation and deflation of the balloon, or I can place a stent basically at the site of blockage, which is that is angioplasty. Second, I can also use it in cases of sudden arterial occlusion for the purpose of embolectomy. So whenever a patient will present to you with a sudden arterial or a sudden vascular obstruction, but in those conditions for embolectomy also we use the Fogarty's catheter itself. Next important, if I talk about beta, is the next one. Very good. This is classically known as which catheter? Swan-Gange catheter. So this is a catheter definitely beta with multiple ports attached to it. And if I talk about the Swan-Gange catheter, it is generally used to measure which kind of pressures. So we know beta that the Swan-Gange catheter is known to measure two pressures beta. One is PCWP, that is pulmonary capillary wedge pressure, which is the reflection of the left-sided heart pressure. Next important, if I talk about beta, is CVP, that is central venous pressure. And we know central venous pressure is a reflection of the right-sided heart pressure beta. Important, PCWP and CVP measurement is very, very important in a patient of shock. Why? Because when a patient of shock is brought to us and whenever we have to start giving IV fluids in that patient, that initial fluid, how much it should be given, you'll get to know with the help of these pressures itself. The best parameter to determine the fluid to be given in a patient of shock will be PCWP beta. I've told you the best parameter to decide the amount of fluid given in a patient of shock is PCWP, that is pulmonary capillary wedge pressure. Followed by second best is CVP, that is central venous pressure. Practically, we use CVP more commonly because it is easier to measure. Okay, but theoretically, best is going to be PCWP itself. That is important. Clear? Next important, what is this picture of? Very good. So this is nothing else but a central line kit beta. Okay, this is nothing else but a central line kit, and I hope all of you are quite aware beta that central line kit can also be called as CVC. What do I mean by CVC? Very good. So please remember central line can also be called as CVC, that is a central venous catheter. Do not get mistaken for this term. It is the same thing. Central line or a central venous catheter is one and the same thing. Important is, please tell me for central line insertion, which is going to be the best site? So please remember beta, the best site definitely for the central line insertion is nothing else but the subclavian vein. So subclavian vein is considered as the best site for the central line insertion. What is the side effect associated with this? Pneumothorax. If the needle goes too deep, the patient will have a risk of pneumothorax. Next, which is the most common site definitely for insertion of the central line? Very good. IGV, that is internal jugular vein, is considered as the most common site for insertion of the central line. And which is the least common site? So we know the least common site preferred for central line insertion is the femoral vein. Now, मुझे बताओ why femoral vein is considered as the least common site? So we know femoral vein is considered as the least common site for central line insertion due to the risk of infections and thrombosis. Highest risk of infection and thrombosis is associated when you insert a central line in the femoral vein beta. That is important. Now, please tell me what is going to be the most common complication of central line insertion. Very good. What is that? Catheter related sepsis. Very good. So please remember the most common complication of a central line insertion beta is nothing else but a catheter related sepsis. Matlab, the infection is basically due to that central line itself. So catheter related sepsis is going to be the most common complication associated with central line insertion. That is important. मुझे बताओ the three important indications I have told you for central line insertion. कौन सी condition में central line डाली जाती है? First, तो one definitely if the patient is going to have a prolonged hospitalization बेटा चलो उसमें burns patient or any patient of shock wherever the peripheral veins are not visible. So whenever peripheral IV access is not possible beta. Next, chemotherapy. We know chemotherapy में anti-cancer drugs are directly given via the central line itself. And last, TPN, that is total parenteral nutrition beta. We know total parenteral nutrition may we have to give sugar rich fluids beta, where the best route for giving the TPN is nothing else but the central line itself. Reason, if you give the TPN via the peripheral IV line, there will be a high risk of infections. Therefore, we avoid that beta. That is what is important to be remembered. No issues with this. These are the things to be remembered about the central line insertion. Next important, what is this recent NEET PG question? Very good. So here you are able to see a picture basically beta, and that is nothing else but a Romovac suction drain. This was the recent NEET PG question also. If I talk about Romovac suction drain beta, why we are calling it a suction? Because the pressure generated inside the drain is going to be negative pressure, which creates vacuum or suction beta. That is important. Now we know Romovac suction drain is inserted after all those surgeries where there will be a high risk of fluid or blood collection after the surgery beta. The most common surgeries will be breast surgeries like MRM, that is modified radical mastectomy, or thyroid surgeries beta. So after a breast or a thyroid surgery beta, Romovac suction drain is commonly inserted. Reason, we know the most common complication of a modified radical mastectomy is seroma. We know seroma is nothing else but collection of serous fluid after the breast surgery called as MRM beta. Okay, and for to prevent that seroma, we have to insert a Romovac suction drain. Next, what is the most common complication of a thyroidectomy or a thyroid surgery? Hmm? Hemorrhage or hematoma, yes. So definitely to prevent that hematoma to be formed after a thyroid surgery or a thyroidectomy surgery beta, we have to insert a Romovac suction drain. That is what is important to be remembered. No issues with this. Now, this is the miniature version beta. What is this drain called as? This drain is classically known as the Jackson-Pratt drain beta. In Jackson-Pratt drain, we don't have a container, rather we have a bulb over here beta. But this is also a negative pressure drain beta. Here also suction or vacuum is going to be created. Next, another thing, if you see, the tubings of the Jackson-Pratt drain are going to be circular or flat. Flatter tubings will be there beta. And Jackson-Pratt drain is generally used after minor surgical procedures like which biopsy? Sentinel lymph node biopsy. Now, in case if we do a sentinel lymph node biopsy, there's a high chance beta that there can be a lymphatic leakage after this procedure. So to prevent that, we have to insert a Jackson-Pratt drain beta after a sentinel lymph node biopsy. What are sentinel lymph nodes? The first draining lymph nodes of any cancer will be called as sentinel lymph nodes beta. That has to be remembered. एक बार जल्दी से सब एक साथ. First, for breast cancer, what are the sentinel lymph nodes? We know for breast cancer, axillary lymph nodes are going to be the sentinel lymph nodes. For gastric cancer, the celiac lymph nodes. For gastric cancer, the sentinel lymph nodes are the celiac lymph nodes, beta. For gallbladder cancer, very good. For gallbladder cancer, it is the lymph nodes of Lund, beta, which are going to be the sentinel lymph node. Lymph nodes of Lund present within which triangle? Calais triangle. Very good. Present within which triangle? Calais triangle. Recent INS set question this time. क्या था? Which among the following does not form a boundary of the Calais triangle? And answer was inferior edge of liver. ठीक है, क्लियर? तो यही क्वेश्चन था, इसीलिए मैंने बोला है कि वो गूगल पे गलत है. ठीक है, तो दैट इज व्हाट इज इंपॉर्टेंट. कोलेसिस्टोहेपेटिक ट्रायंगल इज द आउटर ट्रायंगल बेटा, द इनर स्मॉलर ट्रायंगल इज कैलेस ट्रायंगल. ठीक है, तो कोलेसिस्टोहेपेटिक ट्रायंगल की बाउंड्रीज आर फॉर्म बाय सुपेरियरली बाय द inferior edge of liver, medially by the common hepatic duct, and laterally by the cystic duct. What is the content of that cholecystohepatic triangle? Cystic artery and the right hepatic artery, beta. Now, in that we have a smaller triangle called as the Calais triangle. Calais triangle की boundaries are formed by superiorly by the, याद रखना, तो cystic artery is the content of cholecystohepatic triangle, but a boundary of the Calais triangle, beta. Superior boundary of Calais triangle is formed by the cystic artery. Medial boundary same, that is common hepatic duct, and lateral boundary same, that is cystic duct. What is the content of the Calais triangle? The lymph nodes of Lund, which are the sentinel lymph nodes for gallbladder cancer, beta. That is important. Next, what is the sentinel lymph nodes for urinary bladder cancer? Obturator lymph nodes. What is the sentinel lymph nodes for a prostate cancer? Same. Bladder and prostate cancer में sentinel lymph nodes will be obturator group of lymph nodes. Beta, it will be the obturator lymph nodes. No issues with this. Last, what is the sentinel lymph nodes basically, beta, for testicular cancer? So please remember, for the testicular cancer, it is the pre-aortic and the para-aortic lymph nodes, beta. ठीक है, testis drains over here directly. ठीक है, तो testicular cancer में the sentinel lymph nodes will be the pre-aortic and the para-aortic lymph nodes in the abdomen. And lastly, for the penile cancer, the sentinel lymph nodes are going to be the superficial inguinal lymph nodes. ठीक है, तो inguinal lymph nodes are going to be the sentinel lymph nodes for a penile cancer. That is what is important. Yes. In cases of penile cancer, the sentinel lymph node biopsy is known as Cabana's procedure. So sentinel lymph node biopsy for a penile cancer, beta, is known as the Cabana's procedure. I've told you that earlier. Okay? Chalo. So that is important. Now integration should be started. Now nobody is going to give a reason कि नहीं ये तो सब mix क्यों हो रहा है, ऐसा ही mix ही होगा एग्जाम में भी. तो be aware of that. You have to shift your gears definitely, बेटा. ये तो मैं एक सब्जेक्ट में कर रहा हूँ, एग्जाम में तो मैं 19 सब्जेक्ट में ऑटोमेटिकली गियर्स चेंज करने पड़ते हैं बेटा. एंड दैट पर्सन हु नोज दिस क्वाइट वेल इज एबल टू इजीली आंसर द क्वेश्चन फास्टर. दिक्कत किन लोगों को आती है? जो वो गियर्स फास्ट चेंज नहीं कर पाते, वो एक सब्जेक्ट में अटके रहेंगे, अगला सब्जेक्ट में उनको याद ही नहीं आएगा कुछ, तो थोड़ा टाइम लगता है सेटल डाउन होने में, फिर अगला सब्जेक्ट याद आता है. तो ऐसा नहीं करना है, इंटीग्रेशन रिवीजन में ही स्टार्ट कर दो सो दैट एग्जाम में आसानी हो. क्लियर? जैसे मैंने पहले भी बोला था, उससे और एक फायदा होता है दैट आई हैव डन इन माय प्रिपरेशंस, दैट इज भले ही तुम मीजल्स फॉर एग्जांपल बेटा फॉर एग्जांपल मीजल्स तुम पीएसएम से पढ़ रहे हो, डजंट मैटर, ट्राई टू रिकॉल एवरीथिंग अबाउट मीजल्स दैट यू नो फ्रॉम ऑल द सब्जेक्ट्स, दैट इज डर्मा हो, माइक्रो हो, पीडिया हो, जहां जहां से जो जो याद आ रहा है ट्राई करो रिकॉल करने की. ठीक है, मतलब भले तुम मीजल्स का वैक्सीन पढ़ रहे हो, try to remember the strain also, try to recall the features also, try to recall definitely बेटा the complications also. तो उस वजह से आसानी होगी बहुत सारे टॉपिक्स को इंटीग्रेट करने में और याद रखने में भी. ठीक है, so do that. Next important are the surgical instruments known as staplers. The first one is a linear stapler, which has been again a previous year question of FMG examination, beta. And please tell me, linear stapler is generally used for which kind of surgeries? So we know that definitely linear stapler is generally used for GI surgeries, that is gastrointestinal surgeries, beta, like sleeve gastrectomy or Dohlmann's operation. Sleeve gastrectomy, which is a bariatric or a metabolic surgery done for weight loss, and second Dohlmann's operation, which is the surgery of choice for large Zenker's diverticulum. Very good. Next important is the second one is a picture of a circular stapler, and circular stapler is used for which procedure? Very good. We know circular stapler is generally used in hemorrhoidal surgery. What is the surgery of choice for hemorrhoids nowadays? Hemorrhoidopexy. Please remember, beta, that the stapler hemorrhoidopexy is considered a surgery of choice for hemorrhoids nowadays. Reason: stapler hemorrhoidopexy, when you do, the blood loss is going to be more or less. Less. That's the reason stapler hemorrhoidopexy is the surgery of choice for hemorrhoids nowadays. If that doesn't help, or if there is a recurrence, then we go for a better surgery, and that is hemorrhoidectomy. Okay, but surgery of choice is hemorrhoidopexy. ये याद रखना. Hopefully cleared all of you now. Next important, if I talk about few surgical instruments, beta. The first surgical instrument that you are able to see over here. What is this? Definitely, this is nothing else but a forceps or scissor. So please remember, beta, this is nothing else but a forceps. Definitely. Why forceps? Rachet is present. If rachet is present, it is a forceps. If rachet is absent, it is a scissor. That is important. Now, here you are able to see a forceps, definitely, beta. Okay, which is having sharp edge over here. What is this forceps likely to be? Very good. It is the coach's forceps, definitely, that we have, beta. Okay. Slightly curved end is going to be there. So this is coach's forceps. Bolo, coach's forceps is generally used for. Very good. We know whenever we have to crush any tissue or whenever we have to clamp something, we can use Kocher's forceps. But important uses from Ops and Gynae beta, where you use this Kocher's forceps definitely बच्चे for ARM, that is artificial rupture of membranes, that is done for induction of labor or to start the labor beta. अगर किसी में labor नहीं है started, तो तुम ARM कर सकते हो with the help of Kocher's forceps beta. ठीक है? Next important instrument that you are being given bit over here. Just it is this forceps over here. This is high forceps or low forceps? Low forceps beta. This is a low forceps or an outlet forceps bache because it has a shorter handle. And this is classically known as Wrigley's forceps beta. These is the outlet forceps known as the Wrigley's forceps. Okay, this is the Wrigley's forceps definitely that we are going to use. Next important, what is this next picture? It is Valsalem beta. Yes. So the next instrument that you are able to see, it is definitely Valsalem bache. Again, Obsgyne instrument itself. Okay. So please remember Valsalem. For example, whenever you have to take a biopsy beta, you have to hold the cervix with the help of this Valsalem itself. Okay. So that is a Valsalem basically. Okay. And for biopsy, definitely, which two speculums can be used? One can be the Cusco speculum. Second is the Sim speculum beta. Cusco speculum is a self-retaining one. Sim speculum is a non-self-retaining one beta. That is important. Next important, what is this? Very good. This is nothing else but the Mayo's towel clip beta. So this is a Mayo's towel clip. That is whenever we have to fix the surgical drapes beta during surgery. For fixing the surgical drapes or fixing the suction during the surgery beta, we are going to use the Mayo's towel clip. Next. So we know that definitely this is a forceps beta because it has a rachet. This forceps has triangular blades over here with fenestrations. And this forceps which is there, it is classically known as the Rampley's sponge holding forceps. So whenever you have to clean the surgical site beta, we obviously clean the surgical site with the help of this Rampley's sponge holding forceps. We hold the gauge pieces inside this Rampley's sponge holding forceps and then we clean the surgical site beta. For cleaning the surgical site, what is the solution that you tend to use? It is a combination of two things beta. One is 5% of povidone iodine or betadine. Second, chlorhexidine. So please remember, initially हम scrub करते हाथ से. That is 7.5% povidone iodine. Then we paint, and painting or cleaning which is there, it is done with the help of 5% povidone iodine along with chlorhexidine. याद रखना. Now important, जो cleaning करते हो definitely बेटा, it is sorry done in the abdomen basically from medial to lateral or lateral to medial. Medial to lateral. Abdomen pit should be medial to lateral. Thigh pit should be lateral to medial. That is from a hygienic to a unhygienic area beta. That is what is important to be remembered. Next, इधर ही बता दो basically that sorry, hair removal is also done for cleaning of the parts beta. So whenever we have to do cleaning of the parts before surgery, hair removal has to be done. What is the best method of hair removal? Clippers beta. The best method of hair removal is clipping or the hair clippers बच्चे, followed by razors. So clippers followed by razors beta definitely is the best method. What is the best time for hair removal? On the table. The best time for hair removal is on the table beta, followed by just prior to surgery. So best answer will be on the table. अगर नहीं option में तो answer it है just prior to surgery. That is what is important. Hopefully clear to all of you now. Do remember this. Next important, this is nothing else but the smallest artery forceps. And we know the smallest artery forceps is called as mosquito forceps beta. So this is the mosquito forceps that we have, bache. It is generally used for dissection. Next is the artery forceps. This is a straight artery forceps beta, and straight artery forceps is known as Spencer Wells straight artery forceps beta. Okay? So please remember the straight artery forceps is also known as the Spencer Wells forceps as well. It is generally used to clamp a bleeding vessel beta, that is to achieve hemostasis. तो याद रखना artery forceps का काम होता है to clamp a bleeding vessel to stop the bleeding or to achieve hemostasis beta. That is important. Next is this tissue forceps beta. These are the two tissue forceps. The first one is called as the Ali's forceps. Ali's forceps is going to have sharp or blunt edges. Sharp edges beta. We know Ali's forceps is going to have sharp edges or tooth edges beta, and therefore it will be used to hold which kind of structures? We know that definitely the Ali's forceps, it is generally used to hold tough structures like fascia beta or tendon for that matter. Whereas if I talk about this forceps, that is a Babcock's forceps. Babcock forceps, you can see the ends are curved beta with fenestrations in them. And this curved forceps known as Babcock's forceps, it is used to hold which kind of structures? It is generally used to hold delicate tubular structures beta, right? So we know that the Babcock's forceps is generally used to hold delicate tubular structures. Tubular structures like bowel, fallopian tube, ureters, common bile duct, these kind of structures, जो भी tubular होते हैं और delicate होते हैं बेटा, उनको पकड़ने के लिए we are going to use the Babcock's forceps. Important, has come earlier. Understood? Next important, if I talk about beta, it is this one. What is this? Which retractor? It is known as the Zerney's retractor beta. Okay? So this is known as the Zerney's retractor. Self-retaining or non-self-retaining? As you are not able to see any screw over here beta, it is a non-self-retaining retractor called as the Zerney's retractor. Miniature version jo hota hai, it is called as the cat's paw retractor beta. Next, very important. Very good. So we know definitely beta this retractor which is there, which is extremely concave, is known as the Doyen's retractor. Bolo, gynae se important क्यों है? Very good. We know beta in any lower abdominal surgery like a LSCS or a lower segment cesarean section, if you want to retract the urinary bladder beta, we need to use the Doyen's retractor itself. So please remember the Doyen's retractor is going to retract the bladder. And this has been a question that which among the following is the function of the below given retractor? Answer is to retract the urinary bladder. Next important, this reverse L-shaped retractor is Lagenbach's retractor beta. This reverse L-shaped retractor which is there, it is Lagenbach's retractor. How to differentiate between Morrison's and Lagenbach's? Do remember that Morris which is there beta. Morris retractor is going to have a wider blade basically beta because it is used to retract the solid organs like liver. Okay, this is going to have a very thin blade basically, a rectangular blade, not a square one. Understood? If I talk about the next one now, we know this is important from your ENT surgeries beta. Why? Definitely this is nothing else but a mastoid retractor beta. This is nothing else but a mastoid retractor. We know mastoid retractor is that it is generally used in the surgeries like MRM. What is MRM? Modified radical mastoidectomy. What is MRM used for? CSM. So in patients of unsafe CSM, the surgery of choice is MRM, where we tend to use the mastoid retractor. Next picture is of, now definitely it is a square or a wider blade beta. This is known as the Morris retractor, which is generally used to retract solid organs like liver. During which surgery? Very good. During cholecystectomy, whenever we have to retract the liver upwards beta, you are going to use the Morris retractor itself. Okay? Next important, ये बीच वाला तो Doyens है. I'm not asking about that. Doyens has been fixed over here. But this is a self-retaining retractor called as Balfour's retractor beta. So please remember, this is a self-retaining retractor known as the Balfour's retractor, generally used for the abdominal surgeries, beta. So for abdominal surgeries, we are going to use this Balfour's retractor. Next, for example, if there is a abdominal surgery which is going to take almost beta 8 hours, 10 hours, then in those conditions, definitely, usually in case of cancers, beta, right, like pancreatic cancer, where we perform a Whipple surgery. So in those conditions, we need a system, beta, where all these retractors can be fixed. What is this system called as? Very good. So this system is classically known as the Book-Walter system, beta. So Book-Walter system is generally used to fix multiple retractors during major abdominal surgeries. Next important is the Sarkari question of your exam. Bolo. Very good. So this is nothing else but a picture of Varus needle. Intentionally, I have included this picture. You know the picture that we have discussed in the book and the TNDs. This is the picture that has been commonly asked in the recent examinations. Only difference is this is a completely metallic needle. ठीक है तो यहाँ पे जो valve है बेटा it is also not made up of plastic, it is also made up of metal beta. That is the only difference. So this is also a Varus needle itself, and we know that Varus needle is generally used for which kind of surgeries? Laparotomy or laparoscopy. So we know that definitely beta Varus needle is generally used for laparoscopic surgeries. Why it is used for laparoscopic surgeries? To create pneumoperitoneum. We know in a laparoscopic surgery, bache, we have to create pneumoperitoneum by insufflating the gas within the abdominal cavity or peritoneal cavity. And to create pneumoperitoneum, the gas that is inserted is known as CO2 gas, beta, that is a carbon dioxide gas. Okay, so please remember the needle used for creating pneumoperitoneum is Varus needle, and the gas used to create pneumoperitoneum is carbon dioxide gas. That is what is important to be remembered. Next, another is a structure of a forceps itself, beta. Only it does not have a ratchet, and this is classically known as cheatal forceps. If it is having very curved end, beta, it is a cheatal forceps. It is generally used to remove gauge pieces, beta, from sterile drum, or to remove any kind of sterile surgical instruments, beta, to hold the gauge pieces and sterile instruments. Next is what? This is also a self-retaining retractor which has a screw. Very good. It is known as a Jaws thyroid retractor. By the name, it is evident that the Jaws retractor is generally used for all the thyroid surgeries, beta. So thyroid surgeries mein we can use this self-retaining retractor called as the Jaws thyroid retractor. And the last one is Allison's forceps, beta. We know that Allison's forceps which are there, they are definitely used for holding or retracting the lung, beta. During a cardiac or a cardiothoracic surgery, we retract the lung with the help of Allison's forceps, beta. Hopefully clear to all of you now. So these are the instruments, definitely. Majority of the instruments I've covered. Okay. Still, there can be some instruments which will be out of the box, especially. ठीक है तो इधर आके वापस आके हमारे ऊपर नहीं फोड़ना होता उसका भंडा बिकॉज मेजोरिटी ऑफ द इंस्ट्रूमेंट जो नए आते हैं वो मोस्टली ऑफ था से दिया जाता है स्पेशली ऑफ था बाकी कोई सब्जेक्ट से उनको ज्यादा इंटरेस्ट नहीं होता क्योंकि उनको पता है ऑफ था के इंस्ट्रूमेंट्स ना कोई पढ़ाता है ना यूजुअली कॉमनली कोई देखता है in MBBS. तुम्हें ही नहीं, even for IMGs कोई नहीं पढ़ाता usually, but still they tend to ask you because they want to trap you in that question. ठीक है? Now important if I talk about is this, let's talk about sutures. The first suture is known as catgut suture. Now when I talk about a catgut suture, beta, please tell me, catgut suture is absorbable suture or a non-absorbable suture? So we know catgut sutures are going to be absorbable sutures, beta. Second, they're natural or synthetic? Natural suture. तो अब अगर मैं बोलूं catgut sutures are absorbable, तो please tell me their absorption time. They are absorbed within a span of 60 days, that is 2 months, beta. So catgut sutures are absorbed within 60 days or 2 months span. Next important, they are absorbed by the process of enzymatic digestion or hydrolysis. So all the natural sutures are absorbed by the process of enzymatic digestion. Next important, it is a natural suture, so it is derived from. So definitely we know that as it is a natural suture, it is derived from the sheep's gut submucosa, beta. So from the sheep's gut submucosa, the catgut suture has been made. And last, what is the preservative or the chemical used to store the catgut suture? Isopropyl alcohol. So we know isopropyl alcohol is used to store the catgut suture. Another question that I will integrate with microbiology and PSM, and that is disinfection of catgut suture is done by. Disinfection of catgut suture is done by. Disinfection. Which method? Disinfection of staph aureus, sorry, disinfection of catgut suture is done by which method? All other sutures can be disinfected either by 2% glutaraldehyde or Sidex or by autoclaving, but not catgut. Gamma rays. Okay, only suture definitely that is disinfected with the help of gamma radiation is nothing else but the catgut suture. Important question. याद रखना ये बात. Next important, if I talk about beta, is nothing else but this violet color suture called as Vicryl suture. Vicryl का दूसरा नाम polygalactin suture. We know that Vicryl suture, which is there beta, it is also known as polygalactin suture. That is what is important to be remembered. Now, if I talk about the Vicryl or the polygalactin suture, it is natural or synthetic suture. We know it is a synthetic suture beta, which is man-made. Second, it is absorbable or non-absorbable. We know that Vicryl suture is a absorbable suture beta, and it will get absorbed within a span of how many days? So Vicryl suture gets usually absorbed within a span of 60 to 90 days beta. Definitely that is 2 to 3 months. So Vicryl suture gets absorbed within a span of 60 to 90 days or 2 to 3 months beta. That is important. And this suture will be absorbed by which process? Hydrolysis. All the synthetic sutures are absorbed by the process of hydrolysis beta. Next important is if they ask you where is Vicryl suture used, तो ये बताओ मुझे it is used for skin suturing or viscous suturing. Viscous suturing. Viscous is internal organs beta. So we know that was a previous year question that for bladder and bowel repair which suture is used. So we know for bladder and the bowel repair beta the best suture to be used is Vicryl. So for all the internal organs like the bladder and bowel, the best suture is Vicryl. Next important is the sky blue color suture known as proline suture beta. Now if I talk about proline sutures definitely, so please remember proline sutures की अगर मैं बात करूं, they have more tensile strength or less tensile strength. Proline sutures and nylon sutures, both of them have maximum tensile strength beta. That is what is important to be remembered. Now if they ask you proline suture is generally used for what procedure? Very good. So we know definitely that proline suture will be used for the rectus sheath closure or a rectus sheath repair. तो हमें पता है whenever we perform a laparotomy surgery and after that whenever we have to close the abdomen, we have to definitely suture this tough sheath beta called as rectus sheath, and that is sutured with the help of proline sutures itself, rectus sheath suturing or rectus sheath closure. Next important if I talk about beta is going to be vascular surgeries or vascular anastomosis beta. I have told you for that also we definitely need proline sutures itself. That is important. In case beta, instead of proline beta during rectus sheath closure, instead of proline you have used some other suture beta like Vicryl for that matter, what will happen? Very good. So please remember, if for rectus sheath closure we use other sutures instead of proline beta, which has lesser tensile strength, then there will be high chance that the sutures can break beta and the patient will present to you with complaint of burst abdomen, which is nothing else but wound dehiscence. Wound dehiscence usually occurs basically on which day? The wound dehiscence after the surgery happens usually between 5th to 8th post-operative day beta. Maximum chances on 6th post-operative day will be there. What is the earliest sign of wound dehiscence? Salmon fluid sign. Very good. So salmon fluid sign beta. Salmon fluid sign is the earliest sign where there is a serous discharge or a serosanguinous discharge from the wound happening. Bache. And in cases of wound dehiscence, what should be an emergency treatment? Emergency treatment. Very good. Bogota bag or the Euro bag, laparostomy. Why? Because initially we only clean the wound and keep the wound open beta. Just cover it with the help of Bogota or the Euro bag. So emergency treatment for wound dehiscence or burst abdomen is a Bogota bag or a Euro bag laparostomy. Later on we go for a delayed rectus sheath repair or a delayed rectus sheath closure. Clear? Immediate can be done. Condition being there is no infection. Okay? Chalo. Next important, if I talk about beta, sutures are also classified based on the type of needle that they have. Lastly, two sutures which are used for skin suturing. दो sutures जो skin suturing के लिए use होता है, silk and nylon. So we know silk and nylon sutures are alternatives of each other beta. So silk and nylon suture both can be used for skin suturing बच्चे, that is important, or to fix any kind of drains, catheters, tubes, कुछ भी fix करना होता है. ठीक है? Next important, if I talk about round body needle beta, here when you cut the needle is going to have a round shape beta, or it will have blunt edges. Whereas the another one is a cutting or a reverse cutting needle. Here when we cut a needle beta, one of the edge of the needle is going to be sharp or pointed beta. That is important. Now mujhe batao, round body needle should be used for which kind of structures? Very good. So we know definitely beta, round body needle is generally used for delicate structures beta, like the viscera or the viscous. Whereas the cutting or the reverse cutting needle is generally used for tough structures like the scalp beta. So tough structures like the scalp, we are going to use the cutting or the reverse cutting needle like fascia and scalp. Important is which is the earliest site from where suture removal is done? Face. Very good. The first site beta jahan se suture removal should be done is going to be face. Facial sutures are removed after a span of 3 to 5 days beta. ठीक है, the facial sutures should be removed after 3 to 5 days. Last site from where sutures are removed, abdomen. Abdominal sutures are usually removed after a span of 12 to 14 days beta. Abdominal sutures are removed last, that is around after 12 to 14 days bache. That is important to be remembered. Now, if I classify the sutures further, beta, we know we can classify the sutures as absorbable and non-absorbable, whereas natural and synthetic. The first classification, if I talk about, is if I talk about beta, which sutures are going to be natural absorbable sutures? Answer will be catgut and chromic catgut. So we know that catgut and chromic catgut are natural as well as absorbable sutures, beta. Which sutures are going to be synthetic absorbable sutures? Vicryl, monocryl, and PDS, that is polydioxanone. So please remember the absorbable and synthetic sutures are going to be vicryl, monocryl, and PDS beta. Which suture is non-absorbable and natural? Silk. So which suture is natural and non-absorbable suture? Answer is going to be silk. Which suture is synthetic and non-absorbable? Proline and nylon. We know synthetic non-absorbable sutures are going to be proline and nylon beta. That is what is important. Now, these are nothing else but knots. Identify the first knot. The first knot is surgeon's knot. Why it is called as a surgeon's knot? Yes, the first one is considered as a surgeon's knot. Here you are able to see two throws followed by one throw beta. Whenever we are able to see two throws followed by one throw, it is a surgeon's knot. It is the most secure or the most insecure kind of a knot. So we know that surgeon's knot is the most secure kind of a knot beta. That is important. Next, if I talk about is this one. It is square or reef or granny's knot? Very good. This is a square or the reef knot. Why square or reef knot I am calling it as? Because you can follow the blue color thread beta. Here on both the sides, the blue thread is above the loop. If on both the sides beta, if the thread is either above the loop or below the loop, matlab crossing has happened or not happened? Not happened. कोई क्रॉसिंग नहीं हुई. अगर क्रॉसिंग होती तो एक साइड ऊपर होता, एक साइड नीचे होता. If both the sides are either above or below the loop beta, that means there is no crossing. And if no crossing is there, it has to be the square or the reef knot beta. So this is a square or a reef knot where there is no crossing done. Last one that you are able to see beta, this one is granny's knot. Why it is a granny's knot? Yes, so one side you can see the blue thread on one side is below the loop, on another side the blue thread is above the loop beta, and that's the reason crossing is present. And whenever crossing is present, we call it as the granny's knot beta. And we know that granny's knot where crossing is present is a secure or insecure knot. So we know that definitely granny's knot is an insecure knot which can slip off very easily. That is important to be remembered. ठीक है, चलो next important if I talk about beta is going to be the cauteries. The first one is a monopolar or bipolar? The first one is a monopolar cautery beta that you have to remember. Please tell me, monopolar cautery has one function or two functions? Two function beta. Yellow button is responsible for cutting the tissue and blue button is responsible for coagulation of the tissue. So yellow button cuts, blue button coagulates. That is the two functions of monopolar cautery. Please tell me, in monopolar cautery, will the current pass via the patient's body? Yes, and as the current will pass via the patient's body, for the current to exit out, what is necessary? Cautery pad. So cautery pad is necessary or always required in a monopolar cautery beta. Important. If they say that cautery pad is not properly attached, what it will cause? it will cause burns at the site beta. Okay, so please remember, if cautery pad is not properly attached, it will cause burns at the site. Okay, please tell me, as current will pass via the patient's body in monopolar cautery, it is usually contraindicated in patients having, very good. In patients who are having artificial pacemakers, beta, in those patients, we will not use monopolar cautery. Otherwise, this external current interferes with the heart rhythm or the pacemaker's rhythm, and the patient will develop arrhythmias. That's the reason. Second, it is also not used in which kind of surgeries? As the current definitely spreads in a case of monopolar cautery, you don't use it in case of end artery surgeries or even penile surgeries for that matter. Understood? Next important is this picture over here. This is a picture of a bipolar cautery. Bipolar cautery mein, if you see the cautery beta, it is going to have prongs like end beta. There are two ends. So here definitely, will the current pass via the patient's body? No. Here, as the circuit is completed locally beta, the current will not pass via the patient's body, and therefore can I say it is going to be safe to be used in patients with artificial pacemakers? Yes, so patients who are having artificial pacemakers in them, we can safely use the bipolar cautery. But the drawback or the disadvantage of bipolar cautery is, yes, so it is only and only responsible for coagulation. Can you cut a tissue? No. So cutting of tissue cannot be done, beta. Coagulation is only possible with bipolar cautery. Hopefully understood? Chalo. Done? Next important if I talk about is the wounds beta. Now, when I talk about wounds, definitely, please remember that the first one is a superficial epidermal injury. And this superficial epidermal injury, which looks like scratch mark, is going to be abrasions beta. So we know that abrasions happen when definitely the skin had a friction with a very rough surface, basically beta. And due to blunt trauma or penetrating trauma, we know that abrasions which are there beta, they usually happen due to a blunt trauma. That is important. So friction or a blunt trauma is known to cause abrasions. What we know in road traffic accidents beta, abrasions are commonly seen definitely, and the common abrasions that are seen in road traffic accident, that is called as gravel rash. We know the most common type of abrasion seen in RTA is called as gravel rash beta. Next important is this injury is known as laceration. So we call it as a laceration or a lacerated wound beta. Important. If I talk about laceration or a lacerated wound, please tell me it occurs mainly due to, more commonly due to penetrating or a blunt trauma. So please remember laceration also happens due to a blunt trauma beta commonly. Okay? It mainly happens due to blunt trauma again. Here there will be crushing of tissues or cutting of tissues. So please remember, in cases of laceration beta, there will be crushing of tissues. The nerves, the hair follicles, the blood vessels, and the tissues, everything is crushed over here. Regular margins or irregular margins? Irregular margins. Next important is, definitely it is a suicidal wound, also known as hesitational cuts or tentative cut. But it is which type of a wound? Incised wound, right? So please remember, definitely these are nothing else but multiple superficial cuts beta, and that is nothing else but called as suicidal wounds. And we know suicidal wounds are nothing else but an example of incision or an incised wound itself. Important is, if I talk about incised wound, it happens due to blunt or penetrating trauma. We know that incised wounds are going to happen due to a penetrating trauma, which that is important. But that penetrating trauma will be with a light cutting weapon or a heavy cutting weapon. So we know that incised wound happens with a light cutting weapon, something like a surgical blade or a knife beta. That is important. Okay, so these important things you have to remember. And second, here the nerves, blood vessels, hair follicles, and the tissues will be cut. So there is cutting of tissues in cases of incised wounds beta. That is what is important to be remembered. Now, if they ask you definitely one thing, that if a patient is having injury with a heavy cutting weapon, something like a axe, ठीक है, अगर कुल्हाड़ी से there is a heavy cutting weapon basically beta like a axe, which is going to cause a penetrating trauma, the patient is going to have crushing of tissues. So penetrating trauma due to a heavy cutting weapon with crushing of tissues and fractures, diagnosis is, it is chop wound. Yes. So please remember that penetrating trauma due to a heavy cutting weapon beta, usually like an axe, is known to cause crushing of all the tissues along with fractures of the bone beta. And that is a case of a chop wound then. That is what is important to be remembered. As we know that these inside wounds are nothing else but examples of suicidal wounds beta, which is a favorite question of your examiner. These are also called as hesitational cuts or tentative cuts beta. So suicidal wounds or tentative cuts they are called as. These incised wounds which are suicidal, they're only seen in the accessible parts of the body like the wrist commonly beta. Next important is this over here. What is this? Very good. Here you are able to see beta that this wound which is there, here there is separation of the skin from the underlying structures, and this is called as the avulsion wound, also called as degloving injury beta. This is known as an avulsion or a degloving injury definitely. Here the separation occurs between which two layers, bolo? So here the separation occurs between subcutaneous tissue and the deep fascia beta. ठीक है, मतलब the epidermis, dermis and the subcutaneous tissue get separated from the deep fascia. That is what is an avulsion or degloving injury. This type of injury is mainly seen in run over injury. जब कोई गाड़ी चली जाती है ऊपर से. Next, what is the last one? So definitely better term to be used will be a bruise beta, or it can also be called as contusion. Blunt or penetrating trauma is responsible. We know that this is mainly due to a blunt trauma beta, and the patient is going to have rupture of the blood vessels causing a superficial subcutaneous bleeding, and that is known as bruise or contusion. Bruise specifically for skin related bleeds, contusion specifically for the organ related bleeds beta, but still you can use it as alternative term. Okay. Next important, what is this? Yes. So the patient was having a prolonged immobilization, or the patient was having a prolonged bed rest, due to which all his body weight was supported on the pressure points of his body beta. Okay, and therefore the patient had ischemic necrosis and ulceration at those pressure points called as pressure source or bed source beta. Now, important point to be remembered about pressure source or bed source, that is how much pressure is responsible. Very good. So please remember, beta, the pressure that is responsible for causing pressure sore or bed sore is going to be more than 30 millimeter of mercury. Batao, the same pressure is also known to cause. Very good. So more than 30 millimeters of mercury pressure, you have to remember for two conditions. First, pressure sore or bed force form at a pressure more than 30 millimeters of mercury. And second, compartment syndrome also forms at a pressure of more than 30 millimeters of mercury itself. Now, important is pressure sore or bed sore, which is there, beta. It is usually seen in patients who have been advised prolonged bed rest, beta. In this condition, if they ask you, what is going to be the most common site for a pressure or a bed sore? So we know the most common site for a pressure or a bed sore. Answer is going to be ischium beta. The most common site is the ischium. Why? Because when we sit, all the body weight is supported on the ischium itself beta. Second most common site will be sacrum beta when the patient lies in supine position. And third definitely beta, it is greater trochanter. Whenever the patient lies in lateral position, it is the greater trochanter of femur beta in the thigh. If they ask you how many grades of pressure or bed sores do we have, there are total 4 grades of pressure sore. If there is only a non-blanching erythema, that is redness, that is grade 1. If there is partial loss of skin, that is grade 2. If there is complete loss of skin, that is grade 3. If there is loss of muscle and bone is visible, that is grade 4. So easy hai, redness or erythema 1. Partial loss of skin 2. Complete loss of skin 3. And muscle loss with bone visible 4. That is easy, right? Important is we know for which conditions we need a flap for closure. Grade 3 as well as grade 4. For grade 3 and grade 4 beta, we will need a flap for closure. So what is the treatment in patients of pressure sore or bed sore? So obviously all the dead necrotic material has to be removed. That is called as debridement beta. And along with debridement, definitely we have to do regular dressing. So debridement and dressing is the usual treatment required for pressure or bed sore. Plus minus flap for closure. The flap for closure is only required in grade 3 and grade 4. Clear? Chalo. Next important is which wound? So very good. The next important that you are able to see beta is nothing else but a crush injury or a crush wound. Crush injury may all the soft tissues are going to be crushed over here beta, and it is commonly seen in RTAs, that is road traffic accidents mein beta. Crush injury mein We know that here we have to do a proper debridement, we have to do proper cleaning, and then we have to go for closure. In case a lot of soft tissue has been lost, then we use a flap for closure here also, beta. But if they ask you what is the important complication of crush injury, very good. We know in patients of crush injury, the main complication is a compartment syndrome. I've told you compartment syndrome can happen after two conditions. One, a crush injury. Second, a closed fracture beta. So whenever there is a, see, three reasons याद रखना. First, crush injury. Second, any kind of closed fracture जहाँ पे hematoma or edema is going to form. And third, tight POP slab. ठीक है, तीन conditions जहाँ पे compartment syndrome can develop in a patient beta. The same pressure is going to be there, that is more than 30 millimeters of mercury. And we know here there is compression of blood vessels and nerves, due to which the patient has a severe pain and swelling. If they ask you what is the treatment for compartment syndrome, we know the treatment for compartment syndrome is called as fasciotomy beta. Fasciotomy mein we have to make multiple deep incisions over the fascia so that the pressure gets released beta. That is important. Next important, if I talk about, are the scars. We know whenever wound healing process is going to happen, the scars can form beta. Scars form due to excess deposition of collagen and fibroblast beta. So we know that whenever there is excess deposition of collagen and fibroblast, that leads to formation of scar. If that excess deposition of mature collagen, dense collagen and mature fibroblast happens within the wound limits, that leads to formation of hypertrophic scar. If that excess deposition happens outside the wound limits, it is known as keloid scar. If they ask you which scar is more common in children, we know that hypertrophic scar will be more common in children, whereas keloid scar is more common in young adults between 10 to 30 years of age. Next, which scar definitely has a familial predisposition? We know that keloid scar is going to be associated with a family history. Second, which scar is going to be more commonly seen in the Afro-Caribbean or the black race? We know that the keloid scar is more commonly seen in the Afro-Caribbean or the black race beta. That is important to be remembered. Now, if they ask you, what is the most common site for a hypertrophic as well as the keloid scar? We know the most common site for a hypertrophic and keloid scar both is going to be the sternum beta. That is important. If they ask you what is the treatment for hypertrophic scar usually? Hypertrophic scar. याद रखना, hypertrophic scar majorly does not need any treatment beta, because majority hypertrophic scars will show spontaneous resolution. Only few cases may need a treatment जहाँ पे either moisturizers and mainly silicone gel sheets are applied beta. Clear? Next important, keloid scar की अगर मैं बात करूँ, what is the treatment of choice? The treatment of choice for keloid scar is a tricot injection, that is an intrakeloidal injection of a long-acting steroid known as triamcinolone. तीन जगह पे मैंने triamcinolone बताया सर्जरी में तुम लोगों को. First, it is treatment of choice for keloid scar, where we give an intrakeloidal triamcinolone injection at every 3 weeks. Second, it is also used in cases of chronic it is also used in cases of oral submucous fibrosis beta. Oral submucous fibrosis, which is due to hypersensitivity to betel nut. And third condition, when the patient comes to us basically, surgery mein, when the patient comes to us basically with a non-cyclical mastalgia beta due to costochondritis. Okay, so in that also we give an intralesional injection of triamcinolone beta. Three conditions. If they ask you which is the best treatment for a keloid scar, so we know the best treatment for a keloid scar will be a surgical excision, complete surgical removal. Reason, even after a triamcinolone injection, there is a risk of recurrence beta. So the best treatment is going to be a surgical excision followed by interstitial radiotherapy. Cobalt interstitial radiotherapy is given. Clear about? Chalo. So that is what is important to be remembered beta. So do remember this about keloid scars. Which is the first collagen to appear during wound healing process? The first or the earliest collagen to appear during wound healing process is collagen type 3 beta, and then the collagen type 3 is replaced by collagen type 1 slowly. Most abundant type of collagen in scar tissue, collagen type 1. So when scar tissue is formed beta, the most abundant collagen is going to be collagen type 1. What is the hallmark of wound healing? Granulation tissue. Very good. Hallmark of wound healing process is granulation tissue. What is hallmark of granulation tissue? Patho. Hallmark of granulation tissue. Neovascularization. New blood vessel formation or neovascularization is the hallmark of granulation tissue. Next important, if I talk about this picture over here, superficial or deep ulcers you are able to see. So these are superficial ulcer above the medial malleolus. That means in which area of leg? Gator's area of leg. Superficial ulcers with sloping edges in the gator's area of leg. Diagnosis. Very good. So gator's area of leg में superficial ulcers are going to be venous ulcers itself, beta. Venous ulcers forms due to which condition? Varicose veins, beta. We know that varicose veins is the main reason why venous ulcers are going to develop because there is pooling of deoxygenated blood over there. Venous ulcer में which kind of edges I've told you? Sloping edges are seen in patients of venous ulcer, beta. That is important to be remembered. In case of venous ulcer, the treatment is given via which regime? Very good. In venous ulcer, the treatment is according to the Bisgard regime, beta, where three E's: educate your patient for proper wound hygiene. Second, elevate the limb of the patient, beta, so that the deoxygenated blood does not pool up. And third, elastic compression stockings to prevent varicose veins, beta. That is important to be remembered. No issues with this. Next important, if I talk about, is a deep ulcer, beta, around the foot of the patient, and it is extremely painful with punched out edges. So we know this is a picture of an arterial ulcer, beta. Now, punched out edges are seen in three conditions, beta. First, it is usually seen in cases of arterial ulcer. Second, it is seen also in patients of trophic ulcer. And third, syphilis, beta. ठीक है, तो please remember तीन conditions: arterial ulcer, trophic ulcer, and syphilitic ulcer. All these three conditions will definitely have punched out edges, beta. Important, we know that arterial and trophic ulcer, both of them are seen in the foot, whereas syphilitic ulcer is seen in genitalia. So that is easy. But how do you differentiate a arterial or a trophic ulcer? Very good. Both of them are seen in foot. Both of them have punched out edges, but arterial ulcers are going to be extremely painful. So if the ulcer is extremely painful with punched out edges, the diagnosis has to be an arterial ulcer. Treatment is going to be revascularization and dressing, beta. Why? Because if the arterial blockage is not relieved, the blood flow will not restart, beta, and the ulcer will not heal. So revascularization and dressing should be done. Next picture is of. Very good. Here you are able to see, beta, an ulcer in the sole of the foot, which is seen. It is going to be painless and it is going to have punched out edges, beta. This is a classical picture of a trophic ulcer. Why trophic ulcers are going to be painless? Very good. Because it is seen in those conditions where patients develop neuropathy or nerve damage, beta. Conditions like diabetes mellitus and leprosy, beta. So we know that trophic ulcers are going to be painless or non-tender along with punched out edges, beta. But the difference that you have to remember that in cases of trophic ulcer, it is usually going to be seen in patients suffering from diabetes mellitus or leprosy. That is very, very important. If they ask you, beta, in cases of trophic ulcer also we have to do debridement and regular dressing itself. Just like a venous or an arterial ulcer, यहाँ पे भी debridement and regular dressing is mandatory. But trophic ulcers sometimes can be non-healing in nature. मतलब तुम 3-3 महीने तक ड्रेसिंग करते रहो, the ulcers will not heal in time. Then what is a special dressing that we use once or twice a week? Wag dressing. Very good. So please remember, beta, the special dressing that we can use in cases of non-healing ulcers is called as a wag dressing, which is a part of negative pressure wound therapy. Important, recent NEET PG. How much is the pressure generated in a wag dressing? Minus 125 millimeters of mercury. So minus 125 mm of Hg, beta, is the pressure, is the pressure used in vacuum dressing or in the negative pressure wound therapy. Next is a picture of with sore. कौन सा साइट है वो? Heel. Calcaneum or heel is the site definitely. When you stand, all the body weight is supported on the heel. So it is nothing else but an example of a pressure sore, beta. So these are nothing else but pressure sores or pressure ulcer that you are able to see. One important site is also going to be heel, beta, for this. Clear? Treatment is same, debridement and dressing. Next important is ulcer where the patient had a history of burns. Very good. So here the patient had a burn scar, beta, and over that burn scar, this ulcer has developed. This is a classical picture of a Marjolin's ulcer, beta, that you need to remember. If I talk about Marjolin's ulcer, two types of history they can give you. Either they can give you a history of burns in the patient, or they can give you a case of chronic varicose veins, beta. They can say it is a case of burns or it is a case of chronic varicose veins. Please tell me, beta, for all other ulcers, the diagnosis was done by investigations or clinically? For all other type of ulcers, the diagnosis is always clinical. We don't need any investigation. But for diagnosing a case of a Marjolin's ulcer, what we need? Why biopsy? Very good. So please remember, beta, biopsy is always needed to diagnose a case of a Marjolin's ulcer. Why? Because it is a pre-malignant ulcer and there is a very, very high risk of squamous cell carcinoma. So to rule out the squamous cell carcinoma, we need a biopsy in cases of Marjolin's ulcer. And treatment in all other ulcers, the treatment was only debridement and dressing, beta. But in a case of Marjolin's ulcer, as it is pre-malignant and can develop into squamous cell carcinoma, we have to go for wide local excision, that is removal of ulcer along with some normal margins, beta. You'll be like, so why you have done it in so details? Reason, as I always told you, one question of ulcer is pertinent in your examination for sure. Okay? So please be aware. Now these are the two finger related or hand related infections, beta, that you're able to see. First is a bacterial infection, bache, in the pulp space of the finger. And bacterial infection in the pulp space of finger is known as fellow, beta. Second important is a bacterial infection in the nail bed, and bacterial infection of the nail bed is known as paronychia, beta. Now we know that both of them, whether it is fellow or paronychia, both of them are bacterial infections caused by the same bacteria known as Staph aureus. The most common cause for both the conditions is Staph aureus, beta. Important is here the patient will have signs of inflammation like pain, redness, and swelling. Along with that, sometimes there can be collection of pus, beta. So what should be the treatment in felon or paronychia? So please remember the treatment. Obviously, as it is a bacterial infection, treatment has to be antibiotics. Along with that, beta, we may also go for a pus drainage. So incision and drainage should be done for the purpose of pus, beta. That is important. Now, if it is a case of fellow, beta, here the person will have a risk of distal phalanx osteomyelitis. And if it is a case of paronychia, do we need to remove the nail also at times? Yes, in cases of paronychia, partial nail excision may be required. Not always, but sometimes. Clear? That is important to be remembered. Viral infection in the pulse space of finger is known as Whitlow. तो अगर pulse space of finger में viral infection होता है, that is nothing else but Whitlow, beta. And what is the most common cause of a Whitlow? HSV, that is herpes simplex virus, beta. HSV is the leading cause for a Whitlow to develop. Patient will complain of painful vesicles in the pulp space of finger, and the drug of choice has to be acyclovir. We know for all the herpes simplex infection, beta, the drug of choice is acyclovir. Understood? Next important is the picture, beta, where you are able to see. Shabash. Here you are able to see same picture has appeared in the examinations earlier, so be aware of this picture. Here you are able to see an ulcerative lesion in the shin of the patient, beta, and this ulcerative lesion is going to have undermined edges. Undermined edges are seen in three conditions. First is pyoderma gangrenosum, second is tubercular ulcer in the neck, and third is chancroid, beta, which is extremely painful. So, three conditions, याद रखना, pyoderma gangrenosum, chancroid, and tubercular ulcers are the conditions जहाँ पे undermined edges are going to be seen, beta. Chancroid is due to which bacteria? Hemophilus ducreyi, beta. That is important. Which appearance is seen? School of fish. School of fish appearance is seen. Shabash. Tubercular ulcer में initially history क्या देंगे? Adolescent patient from a poor socio-economic status coming to you with a neck swelling. That neck swelling is basically due to cervical lymphadenitis, which then develops into abscess. Which kind of abscess is seen in TB? Cold abscess or collar stud abscess. Why? No signs of inflammation will be seen over the swelling, beta. So it is called as cold abscess in TB. Followed by that, the patient will have rupture of the abscess, which can lead to formation of a tubercular ulcer in the neck, which will be having undermined edges. Very good. So this is a condition of pyoderma gangrenosum, ulcerative lesion, undermined edges in the shin of the patient. And please remember that pyoderma gangrenosum was a favorite question of your examiner. Pyoderma gangrenosum is commonly associated with which condition? Very good. It is very commonly associated with ulcerative colitis and rheumatoid arthritis. Most commonly, they will give you a history of ulcerative colitis, beta. No issues with this, anybody? Next important, if I talk about repeated picture. Yes, so here you are able to see beta a rash or a erythema which is seen basically with a central clearing, and here there will be necrosis of skin. This rash will keep on changing the sites beta. So we call this as a necrolytic migratory erythema. So we know that necrolytic migratory erythema is associated with which tumor? Very good. So we know it is associated with a pancreatic neuroendocrine tumor beta arising from which cells? Alpha cells, and that tumor is nothing else but glucagonoma. Repeated question of FMG and NEET PG examinations. Do remember that? Okay. So we know necrolytic migratory erythema is associated with glucagonoma beta. That is what is important to be remembered. मैंने बोला था glucagonoma में there will be 4 Ds in the patient. First, the dermatitis, that is necrolytic migratory erythema. Second is diabetes mellitus, because glucagon will increase the blood glucose levels beta. And next important will be DVT, and last will be depression. Okay. Glucagon levels you have to check. More than 1000 picograms will be diagnostic of a glucagonoma in a patient beta. Clear? Next important, if I talk about, is this picture. Here you are able to see gas filled blisters beta along with excessive foul smell beta. Okay, and the patient may be in sepsis also. This is a classical picture of gas gangrene. What is the most common bacteria causing gas gangrene? Very good. So we know that the most common cause of gas gangrene is a gas producing organism known as Clostridium perfringens. Two conditions in surgery where I have told you Clostridium perfringens. One, gas gangrene. Second, चलो ऑप्शन दे रहा हूं, एम्फाइसेमेटस कोलेसिस्टाइटिस और एम्फाइसेमेटस पाइलोनेफ्राइटिस. Emphysematous cholecystitis. Please remember gas gangrene and emphysematous cholecystitis. जहां पे there is infection of the gallbladder and collection of air or gas in the gallbladder. That condition. ठीक है? तो gas gangrene and emphysematous cholecystitis are caused by Clostridium perfringens, previously called as Clostridium velkai. But emphysematous pyelonephritis is caused by E. coli beta. That is what is important. यहाँ पे we know that the patient can also be in sepsis beta. For diagnosis, we have to do biopsy and send it for culture beta. So take a biopsy of this patient and send it for culture basically, which will confirm the diagnosis. Treatment, what is the first step in management? Basic resuscitation, that is IV fluids. Please remember, basic resuscitation should be the first step in this patient, because patients of gas gangrene can be in septic shock and therefore they can be hemodynamically unstable. And for septic shock, the treatment will be only IV fluids or IV fluids plus. Very good. That is important. So for septic shock, the treatment of choice is IV fluids along with IV antibiotics. If you give only IV fluids in septic shock, the patient's condition will never improve. Clear? That is important. And the definitive management will be debridement or amputation बेटा. मतलब अगर छोटे एरिया में है तो डेब्राइडमेंट करोगे, अगर ये पिक्चर जो दिखाया है ऐसा कुछ पिक्चर दिखाता है तो डायरेक्टली एम्प्यूटेशन फिर तो. Hopefully clear. Now let's talk about beta the other two conditions. यहाँ पे there is a necrotizing in bacterial infection. This necrotizing bacterial infection which is shown over here will definitely beta. Okay, please remember. ठीक है. So necrotizing bacterial infection, if I talk about over here, बच्चे, so please remember this is superficial or deep. So this is a superficial necrotizing infection that you are able to see over here. ठीक है. हीरो आपका कैमरा चालू है. ठीक है, चलो. So this superficial necrotizing infection is going to be seen. ठीक है, and the superficial necrotizing infection of the scrotum is classically known as Fournier's gangrene beta. It is classically known as Fournier's gangrene that you have to remember. Whereas the superficial necrotizing infection of the abdominal wall is known as Melanese gangrene beta. ठीक है, तो please remember Fournier's gangrene when it is going to be seen in scrotum, and Melanese gangrene when it is seen seen over the abdominal wall. Important in both these necrotizing infections or necrotizing fasciitis, beta, the initial treatment will be same because these patients can also be in sepsis or septic shock. So treatment has to be IV fluids and IV antibiotics, but the definitive treatment later has to be debridement, removal of the dead necrotic tissue. That is nothing else but debridement to be done. Please tell me, in Fournier's gangrene, do we need to go for an orchidectomy? No, as it is a superficial necrotizing infection, it does not involve the testis. So an orchidectomy is never required in a patient of Fournier's gangrene. Hopefully clear. Next important, let's talk about sepsis now. If I talk about sepsis, definitely beta. So what is the definition of sepsis? Sepsis is a severe form of infection in simple terms. So sepsis matlab kya? Whenever a patient is having any kind of documented infection, any patient having a documented infection, previously known foci of infection was necessary. Now any documented infection is fine beta. Okay. Along with that, features of SOFA beta. So SOFA features should be present. At least two SOFA features should be positive beta. There are total 10 features in SOFA score. Out of them, at least two should be positive bache. SOFA is nothing else but sequential organ failure assessment score. Okay, that will tell us about the severity of sepsis in a patient. So SOFA score definitely should be positive. That is important. If they ask you septic shock, what is the definition of septic shock then? So please remember, when a patient is already in sepsis and now that patient develops low blood pressure or hypotension, that condition is known as septic shock. And the treatment will be IV fluids plus IV antibiotics. Now, if they ask you, whenever a patient comes to you with sepsis or septic shock, the assessment of severity, beta, is going to be done either with the help of SOFA score or a Q SOFA score. Now we know the SOFA scorecard, the full form that has been asked in your examination earlier. So it is nothing else but sepsis related or sequential organ failure assessment score beta. That is the full form of the SOFA score. We know the usual SOFA score is going to have 10 parameters in it beta. But please tell me, in emergency, is it possible for you to look at all those 10 parameters? No. Therefore, the modification in emergency is a Q SOFA score. In Q SOFA score, Q stands for quick. So Q SOFA score means a quick sequential organ failure assessment score where only 3 parameters are going to be included. Those parameters are remembered by the mnemonic bar or GB road. Okay. Important is if I talk about bar beta, so B stands for systolic blood pressure less than 100 millimeters of mercury. A stands for altered mental status, and that altered mental status is assessed with the help of GCS, that is Glasgow Coma Scale beta. Next important, if I talk about R stands for respiratory rate more than 22 breaths per minute beta. Respiratory rate more than 22 breaths per minute. Okay? So please remember, systolic BP less than 100, altered mental status assessed with GCS, and respiratory rate more than 22 breaths per minute. That is important to be remembered about the parameters in the Q SOFA score. Next important, if I talk about beta, is important point, and that is before surgery beta, if you want to give prophylactic antibiotics, what is the best time for the prophylactic antibiotics to be given? Very good. At time of induction beta. So please remember, I've told you the best time basically to mark for giving prophylactic antibiotics before surgery is at the time of induction of anesthesia beta. If that's not an option, then 30 minutes to 1 hour before the surgery or prior to surgery beta. Clear? So yaad rakhna, prophylactic antibiotics are given either at the time of induction of anesthesia or 30 minutes to 1 hour prior to surgery. That is important. Okay? Next important, if I talk about beta, is if we want to prevent any surgical site infection beta. So please remember, definitely surgical site infection agar prevent karna hai definitely. So what is the most important step? Very good. The most important step in prevention beta of in prevention of surgical site infection, that is SSI, is nothing else but hand washing or hand hygiene beta. So hand washing or hand washing or hand hygiene is the most important step in preventing a surgical site infection. Do remember that. Okay? So do remember that. Surgical site infection is any wound infection which happens within how many days of surgery? 30 days of surgery. Severity of surgical site infection is assessed with the help of which score? A sepsis score. Or which grading system? Southampton grading system. So a sepsis score or a Southampton grading system is used to assess the severity of surgical site infection. Clear about? Chalo. So that is what is important to be remembered. Last point from general, and that is nothing else but swellings beta. ये सरकारी बच्चा बोलो क्या है ये? So we know this bachcha is nothing else but a case of dermoid cyst where the patient will have a fluctuant swelling. But how do you differentiate sebaceous cyst from it? Very good. In dermoid cyst, punctum will be present or absent? Absent, beta. So dermoid cyst mein the punctum is absent and no discharge will happen, beta. Okay. Treatment in cases of dermoid cyst will be. So we know dermoid cyst commonly happens on the lateral canthus of eye, beta, the same side, and the treatment has to be a surgical excision. That is, complete removal has to be done. Do not mark any kind of aspiration and marsupialization. No, the treatment is complete surgical excision. Next important, if I talk about, is this picture. Here you can see it is swellings over the scrotum beta, and we know in scrotum we have multiple hair follicles beta, and we know along with hair follicles we have the sebaceous glands. So if the sebaceous glands are blocked, the patient is going to have retention of secretions causing formation of a sebaceous cyst. Please tell me, sebaceous cyst is commonly formed in which sites? Scalp and the scrotum beta. So we know that scalp and scrotum are the common sites where a sebaceous cyst is going to be formed, but it is never seen in palms and soles because palms and soles have no sebaceous glands. So definitely it will never form a sebaceous cyst beta. Important to be remembered is sebaceous cysts which are there. What is the treatment for them? So here also in case of sebaceous cyst, the treatment is surgical excision. We know sebaceous cyst will also present to you with a fluctuant swelling, but it will have a punctum and a whitish paste-like discharge. Okay, treatment is surgical excision. Next, what is the swelling given in the next picture? Why you are calling it as parotid swelling? Any cheek swelling which lifts up the ear lobule has to be a parotid swelling, beta. This is the hallmark of parotid swelling, that the ear lobule is lifted up by the parotid swelling, beta. Now, this can be due to a parotitis, it can be due to a parotid abscess, or it can be due to a parotid gland tumor. Most common salivary gland tumor or most common parotid gland tumor? Answer is, so we know the most common parotid gland tumor or salivary gland tumor is a pleomorphic adenoma. Benign or malignant? We know pleomorphic adenoma is going to be benign and only involves the superficial lobe of the parotid gland. Please tell me, beta, that in cases of pleomorphic adenoma, for diagnosis, we do a FNSC, that is a fine needle aspiration cytology, and treatment is, the treatment of a pleomorphic adenoma is a superficial parotidectomy. Condition when it is large in size. So when that pleomorphic adenoma is large in size, then the treatment is removal of the superficial lobe, that is superficial parotidectomy. But if it is small in size, then we only remove the tumor called as enucleation. Only removal of tumor is known as enucleation. Now important is, whenever we do superficial parotidectomy, multiple nerve injuries can happen. जिसके ऊपर question आते हैं लगातार बार बार. First of all, which is the most common nerve injured after superficial parotidectomy? सब हो गए. Lingual nerve यहाँ थोड़ी पास होती है यार. जो मैंने वही भूल गया, शाबाश. Most common nerve injured. This is going to happen. Drooping of mouth happens after a superficial parotidectomy. It is a marginal mandibular nerve. The most common nerve injured after a superficial parotidectomy is the marginal mandibular nerve injury, which causes drooping of mouth beta. That is important. If they say patient is having loss of sensations or the angle of jaw, it is greater auricular nerve injury. So after surgery, if the patient experiences loss of sensations over the angle of jaw, the likely nerve injured is the greater auricular nerve. Important, sensations from the face is carried by trigeminal nerve and not the facial nerve. Clear? So yaad rakhna, from whole face the sensations are carried by the trigeminal nerve branches except the angle of jaw from where it is carried by the greater auricular nerve. Next important, After the superficial parotidiectomy surgery, patient comes to you with a complaint that whenever he is eating food, he has flushing and sweating. That is called as Frey syndrome. तो फ्रे सिंड्रोम में सर्जरी के बाद पेशेंट को यहाँ पे रेडनेस होता है और स्वेटिंग होती है whenever the patient eats food. This is known as Frey's syndrome. Frey's syndrome occurs due to injury and regeneration of auriculotemporal nerve. So Frey's syndrome occurs due to the recovery of auriculotemporal nerve. That is very, very important to remember. Next, what is the next swelling? If you are able to see beta a swelling in the floor of mouth, that is classically to be a ranula beta. We know that whenever the sublingual gland is going to get blocked, there will be retention of secretions over here. Ultimately, the sublingual gland will rupture and the mucus will collect in the floor of mouth. That mucus extravasation cyst is known as ranula. It contains excess amount of mucus beta. Important is, so as it contains mucus or a clear fluid, which test will be positive? Very good. So when we flash a torchlight, the whole swelling glows with light. So the trans elimination test is going to be positive. The four swellings in body which are brilliantly positive on trans elimination test. First in the floor of mouth is ranula. Posterior triangle of neck, cystic hygroma. Associated with which condition? Mainly more than Downs? Turner syndrome. Cystic hygroma with Turner syndrome beta. Next important, in the lower back, meningocele, and in the scrotum, hydrocele. These are the four swelling which are brilliantly positive on a trans elimination test. If they ask you in cases of ranula, what is going to be the best treatment beta? Best treatment will be surgical excision. Marsupialization is only done if it is the very first episode or it is an extremely large ranula beta. Okay? Because even after marsupialization, chances of recurrence will be present. Okay? But the best treatment overall will be a surgical excision of the cyst as well as the sublingual gland beta. That is what is important. Which is the most common nerve injured? So we know that the most common nerve injured in any floor of mouth surgery like the ranula surgery is going to be the lingual nerve. And when lingual nerve is injured, patient will have loss of general sensations from which part of the tongue? Anterior two-third of the tongue say there will be loss of general sensations between a lingual nerve injury. Clear about? That has been a repeated question of your exam. Do remember this. अभी ब्रेक चाहिए तुम लोगों को? जाओ.